Thank you, Lina. Dear participants, I would like to thank the European Menopause and Andropause Society and Professor Dimitra Gulis for the possibility to make this webinar on Raloxifene in postmenopausal women. The selective estrogen receptor modulators bind with high affinity to the estrogen receptor and have estrogen agonist and antagonist properties that vary depending upon the individual target organ. The factors that determine the variable estrogen receptor agonist and antagonist activity of SERMs are not fully defined but are under active study. The first generation selective estrogen receptor modulator is tamoxifen, and raloxifene is an FDA-approved second generation SERM. Both of them have an estrogen agonistic effect on bone, thereby increasing bone mineral density and mass by decreasing bone resorption. Both of them have an estrogen antagonistic effect in breast. Tamoxifen has an estrogen agonistic effect in uterus. It induces endometrial hyperplasia and increases the risk of developing endometrial cancer. As you can see on this slide, tamoxifen is a potent risk factor for invasive endometrial cancer, and the risk ratio is in women older than 50 years is 5.33. Raloxifene doesn't appear to have an endometrioid agonistic effects. Unlike tamoxifen, it doesn't increase the risk of uterine cancers. The different effects of raloxifene and tamoxifen on the uterus may be related to structural differences that influence with estrogen-responsive genes are modulated in specific tissues. That is why tamoxifen is not used for the prevention or treatment of osteoporosis. However, if a postmenopausal woman is taking tamoxifen for the prevention or treatment of breast cancer, it may lower her risk of osteoporosis. Unlike tamoxifen, raloxifene is only approved for prevention of breast cancer and shouldn't be substituted for tamoxifen in the adjuvant or metastatic setting, given that it hasn't been compared with tamoxifen in these settings. Raloxifene has a similar protective effect against the development of invasive breast cancer, with a lower risk of thromboembolic events and cataracts by a higher risk of non-invasive in situ breast cancer than tamoxifen. So the labeled indications for raloxifene use are as follows: treatment and prevention of osteoporosis in postmenopausal women and risk reduction of invasive breast cancer in postmenopausal women. Osteoporosis is a common disease that is characterized by low bone mass, microarchitectural disruption, and skeletal fragility, resulting in an increased risk of fragility fracture. In systematic reviews, the worldwide annual hip fracture rate in women ranged from less than 100 to nearly 600 per 100,000, and vertebral fracture rate from less than 100 to almost 1,400 per 100,000, depending on the region. A clinical diagnosis of osteoporosis may be made in the presence of fragility fracture, particularly at the spine, hip, wrist, humerus, rib, and pelvis, without measurement of bone mineral density. Fragility fractures are those occurring from a fall from a standing height or less, without major trauma such as motor vehicle accident. An Endocrine Society clinical practice guideline recommends treating postmenopausal women at high risk of fractures, especially those who have experienced a recent fracture, with pharmacological therapies as the benefits outweigh the risks. Women with the highest risk of fracture are the ones most likely to benefit from osteoporosis drug therapy. Therefore, selection of patients based upon fracture risk as determined by a combination of bone mineral density and clinical risk factors is desirable. The guidelines for pharmacologic intervention in postmenopausal women from the age of 50 years show the indications for treatment and the indications are as follows: the history of hip or vertebral fracture, T-score equal or below -2.5 at the femoral neck or spine after appropriate evaluation to exclude secondary causes, T-score between -1 and -2.5 at the femoral neck or spine, and a 10-year probability of hip fracture equal or higher than 3%, or a 10-year probability of any major osteoporosis-related fracture equal or higher than 20%, based upon the United States adapted WHO algorithm. So for individuals with T-scores between -1 and -2.5, fracture risk can be calculated using the fracture risk assessment tool called FRAX. Drugs that are efficacious in the prevention of bone loss include estrogen, alendronate, risedronate, ibendronate, zoledronic acid, raloxifene, and combination of bazodoxifene with conjugated equine estrogen. Raloxifene inhibits bone resorption and reduces the risk of vertebral fracture and is selective estrogen receptor modulator of choice because it has 8-year safety and efficacy data and also reduces the risk of breast cancer. Bisphosphonates could be preferable for the treatment of osteoporosis because they have greater efficacy than SERMs in reducing non-spine and hip fracture. Raloxifene is a reasonable alternative to bisphosphonates for postmenopausal women with osteoporosis, T-score equal or below -2.5 and no fragility fractures, who cannot tolerate or are not candidates for any bisphosphonates, or for postmenopausal women with osteoporosis who are also at high risk for invasive breast cancer. Raloxifene has been shown to increase bone mineral density and reduce the risk of vertebral fractures, but not non-vertebral fractures. Important non-skeletal considerations with raloxifene include reduction in breast cancer risk, increased risk of thromboembolic events, and hot flashes, leg cramps. There is no apparent effect on heart disease or the endometrium. An Endocrine Society clinical practice guideline recommends raloxifene or bazodoxifene to reduce the risk of vertebral fractures in postmenopausal women with osteoporosis at high risk of fracture and with a low risk of deep vein thrombosis, and for whom bisphosphonates or denosumab are not appropriate, or with a high risk of breast cancer. In a meta-analysis of 7 trials, 4 treatment and 3 prevention, raloxifene increased bone mineral density of the lumbar spine, weighted mean difference 1.8, and hip, weighted mean difference 2.1 after 2 years of treatment. In the largest trial, the multiple outcomes of raloxifene evaluation, the MORE trial, lumbar spine and femoral neck bone mineral density increased from 2 to 2.7% in the raloxifene groups compared with placebo. Smoking, which reduces the efficacy of estrogen by accelerating its metabolism, didn't interfere with the anti-osteoporotic effect of raloxifene. The effect of raloxifene on bone mineral density is less than that of menopausal hormone therapy, but there are no comparative fracture data. In the largest trial, the MORE trial, a subset of about 7,000 of the women had lumbar spine radiographs at baseline and after 36 months of treatment. Among the women receiving 60 milligrams and 120 milligrams of raloxifene, 6.6 and 5.4% respectively had new vertebral fractures, compared with 10.1% in the placebo group. The risk of non-vertebral fractures was similar in the 3 groups. Raloxifene reduces the risk of vertebral fracture. However, it hasn't been shown to reduce non-vertebral fractures. The meta-analysis that compared raloxifene with placebo showed a 40% reduction in the risk of vertebral fractures, a hazard ratio 0.60, but no significant effect on reduction in the risk of hip or non-vertebral fractures. Raloxifene may be well suited to younger postmenopausal women with osteoporosis and no vasomotor symptoms, as there is insufficient data to link this drug to long-term harm such as atypical femoral fractures. There are no fracture trials directly comparing raloxifene with the bisphosphonate. Combination therapy, for example, bisphosphonate and raloxifene, is not recommended. Some trials have reported that raloxifene, either taken concurrently or prior to parathyroid hormone, doesn't suppress the bone mineral density response to parathyroid hormone as much as alendronate. Patients previously treated with raloxifene have a good bone mineral density response to parathyroid hormone, but the optimal management, continue versus discontinue raloxifene, is unclear. In women who are tolerating raloxifene well and who are having a good response, improvement, or stable bone mineral density, we suggest not stopping therapy. Safety and efficacy data from clinical trials extend for 8 years, and therefore some clinicians prefer to discontinue raloxifene after 8 years and switch to an alternative anti-osteoporosis agent. Unlike bisphosphonates, SERMs do not have a prolonged duration of action in the skeleton, and there is no residual benefit on bone mineral density after discontinuation of therapy. Ensure adequate calcium and vitamin D intake. If dietary intake is inadequate, dietary supplementation is recommended. Raloxifene is not effective for the prevention or treatment of osteoporosis in premenopausal women. In a 2-year study of 37 premenopausal women at risk for breast cancer, raloxifene significantly decreased lumbar spine bone mineral density by 3.5% and total hip bone mineral density by 1%. Therefore, raloxifene, like tamoxifen, has opposite effects on bone in pre- and postmenopausal women. So, the labeled indication for raloxifene are risk reduction of invasive breast cancer in postmenopausal women with osteoporosis and risk reduction of invasive breast cancer in postmenopausal women with high risk of invasive breast cancer. High risk is defined as at least one breast biopsy showing lobular carcinoma in situ or atypical hyperplasia, one or more first-degree relatives with breast cancer, or a 5-year predicted risk of breast cancer 1.66% or more based on the modified Gale model. Factors included in the modified Gale model include current age, number of first-degree relatives with breast cancer, number of breast biopsies, age at menarche, nulliparity, or age at first live birth. The limitation of use is as follows. Raloxifene doesn't eliminate the risk of breast cancer. Patients should have a breast exam and mammogram prior to initiating raloxifene and continue regular breast exams and mammograms as per current guideline recommendations. Raloxifene is not indicated for the treatment of invasive breast cancer or reduction of the risk of recurrence. Raloxifene is not indicated for the reduction of the risk of non-invasive breast cancer. There is no data available regarding the effect of raloxifene on invasive breast cancer incidence in women with inherited mutations in genes BRCA1 or BRCA2 to be able to make specific recommendations on the effectiveness of raloxifene. The American Society of Clinical Oncology criteria for breast cancer prevention are as follows. Age at 35 years or older, and raloxifene can be used only for postmenopausal women, with a life expectancy of at least 10 years and one of the following. A history of thoracic radiation administered prior to 30 years of age, a history of lobular carcinoma in situ, equal or higher than 1.7% 5-year risk for breast cancer, for example, as determined by the modified Gale model, atypical hyperplasia. Guidelines from the National Comprehensive Cancer Network, the American Society of Clinical Oncology, and the United States Preventive Services Task Force suggest endocrine therapy, tamoxifen, raloxifene, anastrozole, or exemestane for breast cancer prevention. Only tamoxifen and raloxifene are approved by FDA for primary prevention against breast cancer. None of the primary prevention trials have shown a difference in breast cancer-specific or overall survival. For postmenopausal women at increased risk for breast cancer, endocrine therapy for prevention is recommended for a total of 5 years. A choice among agents in postmenopausal women should be individualized based on their comparative risk profiles and patient preferences. For women with normal bone mineral density, either a SERM or an aromatase inhibitor are appropriate, with the choice between them driven by patient preferences regarding toxicity profiles. SERMs and aromatase inhibitors haven't been directly compared in these settings, but indirect comparisons suggest modestly improved outcomes with aromatase inhibitors and potentially better risk-benefit ratio in older patients. Baseline risk of thromboembolism, cataracts, and uterine cancer increases with advancing age. Thus, for older women, older than 60 years of age, especially those with intact uterus, an aromatase inhibitor may be more appealing compared with a SERM. One should monitor bone mineral density in patients on treatment with aromatase inhibitor. A SERM is an acceptable alternative for those who wish to avoid the risks of an aromatase inhibitor, for example, arthralgias and osteoporosis. When using a SERM, we should offer raloxifene if patients are more concerned about uterine cancer and thromboembolic risks than their risk of breast cancer. By contrast, for women who are more concerned about breast cancer prevention or have had a hysterectomy, we should offer tamoxifen. Both tamoxifen and raloxifene are reasonable options for women at an increased risk of breast cancer. When administered for prevention in the trials, treatment was generally administered for 5 years. Raloxifene appears to be a less potent SERM than tamoxifen, with a smaller reduction in new cancers, but the risk of endometrial cancer and thrombosis are also less with raloxifene. The MORE trial, multiple outcomes of raloxifene evaluation with about 8,000 postmenopausal women, showed that raloxifene was associated with substantially reduced risk of invasive breast cancers. In the RUSE trial, raloxifene used for the heart with more than 10,000 postmenopausal women, raloxifene reduced the risk of invasive breast cancer, hazard ratio 0.56, absolute risk reduction 1.2 cases per 1,000 women per year. The benefit was primarily due to a decreased risk of estrogen receptor positive breast cancers. The benefits and risks of raloxifene were also summarized using data from 2 trials in postmenopausal women. Compared with placebo, raloxifene resulted in a reduction in the risk of invasive breast cancer, 9 cases in 1,000 women, risk ratio 0.44, As with tamoxifen, the risk was reduced primarily for the development of estrogen receptor-positive breast cancers. A reduction in the incidence of vertebral fractures, 7 cases in 1,000 women, risk ratio is 0.61. No increased incidence of endometrial cancer, no difference in breast cancer-specific or all-cause mortality. The STAR trial, study of tamoxifen and raloxifene, directly compared tamoxifen with raloxifene. Tamoxifen was slightly more effective at preventing invasive breast cancer. Although both tamoxifen and raloxifene increased the risk of thromboembolic events comparing with placebo by approximately 7 to 9 events per 1,000 women over 5 years, the risk was greater with tamoxifen by approximately 5 cases per 1,000 women. In addition, tamoxifen resulted in greater risks of cataracts and endometrial cancer, particularly in women 50 years or older. The data shows that both terms are effective agents as chemoprevention among women at higher risk of breast cancer. There is no data on the efficacy of raloxifene for breast cancer preventing among premenopausal women. In clinical trials, hot flashes from 8 to 25%, leg cramps from 5 to 10%, and peripheral edema from 5 to 14% were common with raloxifene, were more common with raloxifene than with placebo. There was no difference in endometrial thickness or complaints of breast pain or vaginal bleeding between the active treatment and placebo groups. In the MORE trial, raloxifene therapy wasn't associated with an increased risk of either gallbladder disease or cataracts, risks that are increased with estrogen and tamoxifen use respectively. However, an increased risk of gallbladder disease was seen with raloxifene in the RUTH trial. Raloxifene increases the risk of venous thromboembolic events, as has been described for both estrogen and tamoxifen therapy. The magnitude of this effect is illustrated by the results of a meta-analysis of 9 trials, in which therapy with raloxifene was associated with an increase in the risk of deep venous thrombosis and pulmonary embolism. Odds ratios 1.5 and 1.9 respectively. The magnitude of the relative risk appears similar to that reported with estrogen progestin use. In one of the largest trials, the RUTH trial, 10,101 postmenopausal women, mean age 67 years, with coronary heart disease or risk factors for coronary heart disease were randomly assigned to raloxifene 16 milligrams a day or placebo. Raloxifene was associated with an increased risk of venous thromboembolic events, 103 versus 71 events, hazard ratio 1.44, absolute risk increase 1.2 per 1,000. In the study of tamoxifen and raloxifene trial, the STAR trial, which compared raloxifene with tamoxifen for the prevention of breast cancer, the risk of thromboembolic events was lower with raloxifene than with tamoxifen. In the RUTH trial, raloxifene wasn't associated with an increased risk in overall stroke risk, but was associated with an increased risk of fatal stroke. 59 versus 39 events, hazard ratio 1.49, absolute risk increase 0.7 per 1,000 women years compared with placebo. In a post-hoc analysis, the increased risk of fatal stroke was greater in women who had a high baseline risk of stroke. In the STAR trial, Stroke risk was similar in the raloxifene and tamoxifen groups. Although raloxifene decreases serum concentrations of total and low-density lipoprotein cholesterol, it doesn't decrease the risk of coronary heart disease. According to the Ruth trial, the incidence of coronary events among women younger than 60 years of age was significantly lower than in the raloxifene group compared with placebo. In the STAR trial, the risk of coronary heart disease was similar in the raloxifene and tamoxifen groups. In a study of raloxifene therapy in 12 postmenopausal women with a history of hypertriglyceridemia, while on oral estrogen, 3 of the 12 developed severe hypertriglyceridemia while taking raloxifene. This subset of susceptible women should be monitored closely if raloxifene is subsequently prescribed. In the more core trial, continuing outcomes relevant to VISTA, which recruited postmenopausal women with osteoporosis, mortality was recorded as an adverse event. Overall mortality was lower among patients in the raloxifene group, 45 versus 65 deaths, hazard ratio 0.68. In the Ruth trial, postmenopausal women were recruited with coronary heart disease or its risk factors. There was no difference in overall or coronary mortality rates between the raloxifene and placebo groups. 554 versus 595 deaths, hazard ratio for overall and coronary mortality 0.92. However, there was a significant increase in cerebrovascular mortality, 59 versus 39 deaths, hazard ratio 1.49. In a post-hoc pooled analysis of mortality data from more core and the Ruth trials, overall mortality was lower among women receiving raloxifene, hazard ratio 0.9, primarily due to a lower rate of non-cardiovascular deaths. This data suggests that treatment with raloxifene has the most favorable risk-benefit profile in postmenopausal women at high risk for vertebral compression fractures and breast cancer, but a less favorable profile in women with high risk for thromboembolic disease and stroke. When considering raloxifene therapy, the individual's risk of disease and personal preference are important for weighing the potential benefits and risks. The other effects of raloxifene include the effect, speaking about the effects on cognitive function, an analysis of data from the MORE trial showed that the risk of cognitive decline was no different with raloxifene versus placebo. Speaking about schizophrenia, studies are underway on raloxifene as an adjuvant treatment for postmenopausal women with schizophrenia, particularly promising results in mild presentations of schizophrenia. What about endometrial effects? Unlike estrogen and tamoxifen, raloxifene is not associated with vaginal bleeding, and unlike estrogen, it doesn't increase the risk of endometrial hyperplasia or cancer. And genitourinary effects, raloxifene doesn't appear to affect vaginal symptoms, dryness or dyspareunia, nor does it have any effect on urinary incontinence symptoms. So, in conclusion, the indications for raloxifene are treatment and prevention of osteoporosis in postmenopausal women and risk reduction of invasive breast cancer in postmenopausal women. The route of administration is oral, 60 milligrams once daily. Raloxifene may be well suited to younger postmenopausal women with osteoporosis and or with a high risk of breast cancer and no vasomotor symptoms, with a low risk of deep vein thrombosis and stroke, to reduce the risk of vertebral fractures and of invasive breast cancer, with no apparent effect on heart disease or the endometrium. We have safety and efficacy data from clinical trials for 8 years of therapy of osteoporosis. Effects on bone mineral density diminish relatively quickly, for example, within 1 to 2 years when raloxifene is discontinued. Duration of therapy for breast cancer risk reduction is 5 years. May be used longer than 5 years in women with osteoporosis, where breast cancer risk reduction is a secondary benefit. Raloxifene reduces incidence of invasive estrogen receptor positive breast cancer, also for at least 5 years after completion of therapy. According to the Ruth trial, the absolute rates of events that were decreased, vertebral fractures and breast cancer, were similar to the absolute rates of events that were increased, venous thromboembolism events and fatal stroke. The more minor adverse events, hot flashes and leg cramps, tend to be worse in the first 6 months of administration. Therefore, it is common practice to encourage perseverance with the drug during the first few months of treatment. The risk of thromboembolic events is similar to that with the current use of menopausal hormone therapy. The risk-benefit balance should be considered in patients at risk of venous thromboembolic events of any etiology. Raloxifene should be discontinued in the event of an illness or a condition leading to a prolonged period of immobilization. Discontinuation should happen as soon as possible in case of illness or from 3 days before the immobilization occurs. Therapy shouldn't be restarted until the initiating condition was resolved and the patient is fully mobile. I thank you for your attention. If we have any questions, let's see.
Thank you. Thank you, Dr. Smetnik. Sorry, my microphone was having some issues. Thank you for such a wonderful presentation. And now for the Q&A session, as you said, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar control panel. Okay. We have our first question. It's what are the contraindications of raloxifene?
Well, the contraindications for raloxifene include past medical history of deep venous thrombosis, malignancy, well, active smoking, or any thrombophilia that have the woman. And also pregnancy, but we use raloxifene for postmenopausal women, so we don't speak about pregnancies here. Okay.
Okay. So, well, it seems that, well, we have one more question. How to monitor bone effect of raloxifene?
Thank you. We should monitor the bone effects by dual energy absorption by DXA, by DXA. And we can start with DXA once in, because of course we should do the baseline DXA, and then in 2 years. And if we see that there is an improvement, we can make DXA with less frequency.
Okay. Our next question is there a data on raloxifene post-hip fracture in younger women?
Unfortunately, raloxifene doesn't reduce the hip fracture. So I think it's not the drug of choice in this case. I think so.
Well, Well, we have another question. It was mentioned that the most difficult period are the first 6 months. Is there any thought of additional add-back estrogen or estrogen therapy for this period, these hard first 6 months?
I haven't heard about add-back therapy by estrogen during this period because there is some cross-reaction between raloxifene and estrogen, so they aren't used together in a combination. And I think we can use some non-hormonal drugs to alleviate the symptoms. I think so.
Right. Well, our next question is: postmenopausal patients are given tamoxifen as first choice to prevent breast cancer instead of raloxifene. Why is this so?
We have a lot of data on tamoxifen and its efficacy on breast cancer risk reduction, and different patients we should administer different drugs for different patients. We can see that the safety profile of raloxifene is a bit better than in tamoxifen. However, tamoxifen is more efficacious for breast cancer risk reduction, especially when we are talking about non-invasive breast cancer risk reduction, because raloxifene is not effective for the reduction of risk of non-invasive breast cancer. And also we cannot use raloxifene for the reduction of the risk of recurrence of breast cancer. And here we can use, or as an adjuvant therapy in breast cancer, and here we can use only tamoxifen.
All right. Well, it seems that now we don't have any more questions. Thank you so much, Dr. Smetnik, for conducting the Q&A, for answering the questions. I don't know if you would like to add something else before we conclude this webinar.
Well, I would like to thank you, Lina. I would like to thank all the participants and, of course, the European Menopause and Andropause Society for the wonderful possibility to make this webinar. Thank you so much.
Okay, so this concludes the webinar. Again, thank you so much, Dr. Smetnik, for your presentation and all the attendees for being here today. Have a great rest of the day.
Have a great day. Thank you.